Welcome, everybody. I'm Dr. Gökhan Dokumacıgil from Turkey in Istanbul. In this lecture, in this video series, you will see posterior direct composite restorations from planning to finishing. I'm a restorative dentist specialist, and I'm working as a dentist in my private practice. And this is my clinic, and I mostly work under dental microscope, and also I'm almost taking all my patients' photos, all the procedures, what I am doing. And you will see all the videos and photos which was taken under that microscope and that camera, that lighting system. And let's talk about direct posterior composite restorations. First of all, we must diagnose, we must decide what we want to do. It's not only for the dentistry, but also it's same for everything, every problems. Before we start any kind of work, we should decide how we want to solve the problem. And in that way, we can give information to the patients, and also we can follow our route easily, and we it's better to know what we want to do step by step. Firstly, before we start any kind of posterior restorations, we should know classification, and the first classification is caries classification. There's an international caries detection and assessment system, and this system includes 7 different scores, and the score zero represent sound tooth surface, while the score 1 representing first visual change in enamel, like here, and the score 2 means distinct visual change in enamel. When you compare with score 1 is score 2. Score 2 has more darkened enamel chains. And when it comes to score 3, we still can't see the dentin surface, but there's a localized enamel breakdown, but no visible dentin. And for the score 4, this time we may see dentin surface, underlying dark shadows from the dentin, with or without enamel breakdown. Sometimes we directly see the dentin caries reflection from the bottom. And score 5, here there's a distinct cavity with visible dentin. And when it comes to score 6, it means extensive distinct cavity with visible dentin. And the other classification is the cavity classification. And you all know, we all are dentists, and we know the class 1 cavity has the one side cavity on the occlusal surface of the teeth, and class 2 means DO, distal occlusal, or IMO, mesio-occlusal, or IMO, the mesio-occlusal and distal surface of the tooth. And the other one is class 5, which means the cervical caries, especially. So, before we start any restoration, we should decide what kind of treatment plan we have. For example, in that patient, this number 6 has some color change on the distal side, but when you directly just check on intraorally, you can only see there's a small caries on the distal side of the tooth. For this reason, we must check the X-ray as well. And also, for example, in that patient, on the left side, you are seeing the number 7 and there's some leakage on the underneath the old restoration, former restoration. But in that time, we can't decide our restoration plan just checking the X-ray or radiography. So we must check the intraoral condition of the tooth. And also, we should tell the patients that your teeth may be required indirect restorations such as overlays or dental crowns or inlays, because especially underneath the former amalgam restorations, it's possible that encounter with that kind of crack lines, and you can see the you can see the crack line underneath the lingual cusp. So it's better to take all the steps photos, but if you are not taking photo or not working under microscope, it's very difficult to see that kind of crack lines. And also here the X-ray looks the shows that the tooth has very small cavities and fractured old restoration, and maybe very small caries on the mesial side of the number 6. And after cleaning old restoration and caries, the cavity still looks like class 1 cavity, but in this time we can use some other equipments to decide what's happening on the tooth, what kind of problem on the tooth. Here you are seeing the illumination light to check the proximal caries or also correct lines on the occlusal surface. And there's a correct line on the mesiolingual side, mesiolingual cusp of the tooth. So that means your restoration may turn into indirect restoration from the direct restoration. Before I started to restoration, I was just planning to do direct restoration, but after checking that, after seeing the correct lines, we directly changed our treatment plan. Also, the caries detector dies can show you some correct lines. For example, here I'm applying caries detection dye, and there's a correct line on the distal side, and you can see that correct line on the left side of the photo here. Here is the correct line, so it means that I must clean that correct line. Otherwise, after direct restoration, we may encounter with the leakage or maybe the fracture of the tooth. So that kind of diagnose diagnostic ways may make it easy to decide what kind of treatment plan. And I'm cleaning the distal way, then we directly make it indirect restoration, and we cleaned all the fractured line when you check on the right photo. And I told to my patients, your tooth needs indirect restoration because there were some crack lines on the tooth. That patient has the bruxism, parafunctional activity. So in that kind of issues, in that kind of situations, uh, after that patient especially, uh, I'm be careful, especially when treating the bruxis patients. And the other way is the UV lights, especially when you are removing the old restorations. UV lights may show the former restoration's remainings. For example, I cleaned the old restoration, but the color of the composites is almost same with the origin, the nature tooth. So that kind of UV lights make it easy to see old former restorations remaining. And also here, X-ray again, and after cleaning the surface, I filled the tooth, but the important thing is we should take the X-ray, especially for the after restoration, especially for the deep caries or indirect restoration, cementation. So it's better to check X-ray of the restorations after treatment. And also here you are seeing bone level restoration, and the patient has very severely fractured tooth, and after X-ray, the distal side of the tooth almost at the same level with the alveolar crest, and after gingivectomy, we I saw that the distal side is almost at the same level with the bone, distal bone, and here we must use the rubber dam application to isolate the tooth. Otherwise, it's very difficult to make very dry area without the bleeding. And then we treated the root canals, and after that we finished the base preparation and then cementation. And after cementation, like for the direct restoration, we must take the X-ray of the last condition. Otherwise, we may see the restoration looks fine, but after X-ray, we can see that there's some leads or there's some gaps between restoration and tooth surface. So it's better to check that by using X-ray. And also the patient's complaints may affect your indication. Here, the patient has very small gap, very small fracture on the mesial side, and the main problem was the food infection. And for the when you follow the patient's complaints, then you may decide what kind of treatment you can do. And that patient has the similar problems, similar complaints, and she had the food infection because of the gap black triangle here. There wasn't any caries on the number 6, but there was some gum recession and periodontal problem between the number 5 and number 6. So because of that reason, patient has very big gap here, and before we treated that kind of tooth, we should plan what kind of treatment we can do, because maybe we can make a filling here, or the patient may need some periodontal surgery, surgical steps for the exact treatments. This patient has the similar complaints. He had the food infection on the mesial side of the number 5, and the main problem here, the former restoration, the former dentist created some iatrogenic problem on the mesial side of the number 5, and when he was preparing the number 4, he directly touched the mesial of the number 5, and I think he created some lights on the mesial side of the number 5, and you can make the direct restoration or indirect restoration there. And the other one is the main idea, I think, for diagnose, the patients are applying to the clinic with some complaints. And it's very important to hear the patients because they can give you some small clues, and it can directly show or it can directly, that kind of clues that can directly give you information what kind of problem you may encounter with. And she told that when she had been eating nuts, she heard a cracking sound coming from her teeth. But for on the clinical in the clinical examination, there wasn't any symptom or any mobility on the tooth or the any cost. Then we started the cleaning, removing the old restoration, and after cleaning the restoration, now you can see the crack line on the lingual wall. I didn't do anything, just I hold the lingual cusp by tweezer, and then now my restoration will be indirect restoration. So if the patient told you that gave you that kind of information, we must be careful before our restoration plan, because uh, the fracture line would be underneath the bone level. So that time you may need to extract the teeth, or you may need to extra surgical procedure. So it's very important to hear patients before diagnose, before making our indications. Well, before all the diagnostic steps, we must isolate the tooth before any restorations, because we can use cottons, retraction cords, Operagate, PTFE, Teflon tape, C-type retractor, Optradam, rubber dam. If we don't make a good isolation on the tooth surface, on the restoration area, it's almost impossible to stick the or to create adhesion, to make adhesion on the dentin, on the tooth surface. Because if there's a leakage, like a bleeding, like a saliva, it's very difficult to create a good quality bonding, or to make good quality restoration. So, what kind of isolation methods we can use? It depends of the restoration area. For example, you can use retraction cord for the cervical restorations. So, by using the retraction cord, I can directly retract the gingiva gum nearby the cervical area. In that location, it's very challenging to use rubber dam isolation. So I must prefer the traction cord. Depends on the location of the caries. The other way is Optragate isolation, and especially I'm using it for the bleaching or for cementation of the laminate veneers. So uh, it's not create very good isolation area for the posterior restorations, but for anterior restorations, it's very easy to retract the lips from the restoration area, from to the out of the restoration area, and for the bleaching, it's very useful thing. The other one is PTFE Teflon tape. We use that PTFE for very different area for the isolation. And the other one is the C-type lip retractor. And by using C-type lip retractor, we can make maybe bleaching, but it's especially useful for the photography, to be honest. And the other one is self-frame rubber dam isolation. And you don't need any external rubber dam frame by using this rubber dam system. Ivoclar has that kind of self-framed. Cure has the similar one, and also uh, Roeco has the Colteen has the similar self-framed rubber dam isolation. And the gold standard, is the rubber dam. And let's talk about the rubber dam isolation. Well, actually, uh, 7 years ago, after I finished my my dentistry faculty, uh, I wasn't used to using the rubber dam isolation, and I didn't have a lot of knowledge about the rubber dam. But uh, after I starting my after starting to my PhD, my specialty training, I tried to force myself to use rubber dam because I noticed that taking the photos on the rubber dam, taking the videos on the rubber dam, and working on the rubber dam, it's easier than without rubber dam for me. Maybe it changed, depends on the person, but after I explore for myself the rubber dam, I noticed that it's very easy way to work on the rubber dam isolation. So, where can we use rubber dam isolations? Actually, we have some different indications for the rubber dam. I sometimes use that for the intracoronal bleaching. For example, uh, in that patient, the patient has the gingival problems, and also there's a very inflammatory gingiva gum area nearby the tooth. So if we don't use rubber dam isolation here, or if we don't make a good isolation here, there may be some leakage nearby the cervical area here. So we can keep clean the intercoronal area when we are doing intercoronal bleaching. So here you can directly make one tooth isolation, and you can continue what you want to do. For the root canal treatment, we must use rubber dam isolation as well, because we can avoid the bacterial leakage here. And also for posterior restorations and for the quadrant restorations as well. And also we can use, or we should use, rubber dam isolation when we are removing the amalgam restorations. There was a very complicated restorations here. There was a composite restoration, and there was a amalgam underneath the composite. And to protect your patients from the harmful effect of the amalgam or mercury, it's the best way to isolate the restoration or preparation area under the rubber dam. And also isolation for extreme cases, the rubber dam is the best way. For example, that patient has the mercury fillings, old amalgam fillings, and after cleaning the amalgam fillings, I encountered with some fracture lines. Here you can see the fractures, and I mostly encounter with that problem, especially almost all the amalgam restorations, because they service very long time, but they are metal, they are mercury, they are very tough material, and they are tougher, they are harder than the dentin surface. So they may create that kind of cracked lines under some pressure, under some force, for example, biting or eating some hard things. And then when you are working under rubber dam isolation, it's easier to isolate that dentin. Otherwise, if you are working without good isolation conditions, it's very difficult to isolate the correct lines from the saliva, and it means that you may infect the dentinal surface and that correct line with the saliva as well. And for that patients, we prefer the fiber ribbon placement, and we finish in the indirect way. And also, not only we use the rubber dam for the posterior restorations, we use that for the anterior direct restorations, especially for diastema closure. Rubber dam is very useful to create more anatomic proximal wall, because it's difficult to achieve isolated area in subgingival area here, and rubber dam makes possible to work in gingival pocket without any leakage. And without rubber dam, it's very difficult. You may make it by using retraction cord, but it's very overwhelming. It's very challenging to remove the retraction cord after the restoration, because it like sticks to resin restorations. And with the rubber dam, you can push to the top the gingival area. You can push here to the top, and for diastema restorations, it's very easy to create restoration, like to create the emergence profile, like coming from the gingival pocket. So it gives you better results, and it gives you more aesthetic results. And after restoration, you may see that kind of black triangle, because the rubber dam is directly push top the gingival area. But no worries, because if the interpapilla, if the distance between interalveolar bone crest and the contact point less than 5 millimeter, the interpapilla will show up in time, like maybe 1 month, maybe 3 months, but it mostly show up in time if this distance lower than 5 millimeter. It's not distance between interdental papilla and the contact point. It's the distance between alveolar crest, the top of the alveolar process, and the contact point of the restoration. So that's the main reason why we are using rubber dam isolation, because under the rubber dam, we can make that contact point almost nearby as much as possible nearby the alveolar process. So we can decrease that distance by using rubber dam, and we can see the better results. And it's the follow-up session. Well, there are some elements of the rubber dam isolation, and the main elements are puncture, forceps, clamps, rubber dam sheets, and frames. And the puncture has been designed for different tooth size, the clamp teeth, molars, canine and premolars, upper incisors, lower incisors, but it's totally changed, depends on the patient's tooth, because sometimes you want to restore the wisdom tooth, and the wisdom molars has the similar size with the premolars sometimes. So it's totally depends on the tooth size, but mostly you can prefer that whole size for for your big ratio of your patients. And also the other one is forceps to hold the dental clamps. And the problem is sometimes the when you extend the beak span, there will be an angulation towards the forceps. So you can modify the interface of the forceps to take out easily from the clamps holes, especially for the posterior restorations for the second molar. When you are using your rubber dam clamps, it's very difficult to remove your forceps from the rubber dam clamp just because of the anatomy or structure of your forceps. So you can, if you are using ball head forceps, you may modify it. Well, which teeth should be isolated, especially for anterior or posterior restoration? I mostly prefer to place my clamps far away from my restoration area as much as possible. Otherwise, you may struggle with placing your matrix bands, placing your wedges, and placing other restoration material like a matrix system rings. So it's better to place it far away from the restoration area as much as possible. And for example, in that patient, I was planning to polydiastema restorations from canine to canine, and I placed my rubber dam clamps on the second premolars. Here, you are seeing the posterior restoration, and I was planning the restore second molar, first, second, and first premolar. And here I placed my clamp on the second premolar, second molar, and I also stabilized my rubber dam on the anterior, on the mesial side of the lateral incisors. For the before punching the holes, we should decide where the tooth are located. So if the patient doesn't have any orthodontic problem, and if they have very good occlusion or alignment, we can use that kind of isolation guides. But if the patient has some problems, and if you punch the hole far away from each other, the sheet will be fold. And if you are planning to do restoration here, it's very big challenging to place matrix bands, to place wedges here. So we should be careful before the rubber dam isolation, before punching the holes. And the other way is just looking to the patient's mouth, patient teeth alignment, then creating some modifying, some modification before punching the holes. And the other mistake is if you punch the hole too close each other, the holes that time will be extended and the gum may show up there. And if you are planning to make restoration here, it's almost non-isolated area. But that rubber dam still isolate the lips. But if you are planning to make restoration on the distal side of the lateral incisor, the tooth still non-isolated condition. So we should be careful when we are punching the holes. And the other one is the inversion. And if you don't invert the edge of the rubber dam holes inside the gingival pocket, there will be still micro leakage from the gingiva to the tooth. So we should make a good inversion to create good isolation. And especially if you are planning to place clamp on the dental crowns, I can tell you, don't do that because you may uh, you may encounter with another problem on the patients, such as the fracture of the entire crown or popping out the crown like that, because it directly make pressure from the cervical area, and it directly pop out the indirect crown, directly pop out from the tooth, from the prepared tooth. Here you can use the some different materials like a stabilization cord from Coltin, or some other brands are producing it. And the other method is just cutting a piece of rubber dam sheet. I always cut the left lower edge of my sheet, and I use it like a stabilization cord. The other elements are clamps, and there are two clamps classification. First one is the master clamps and anchor clamps, or the other one, and the second one is the auxiliary clamps. Let's start with the auxiliary clamps. These are my favorite auxiliary clamps number, which you see on the left side on the screen. And the Brinker clamps are very useful materials, auxiliary materials, especially for the anterior and cervical restorations. You can use the B4 Brinker clamps, or you can use 211 or 210 or 209. They all means butterfly clamps. You can cut 211 clamps, but two different 200 clamps. Firstly, you are cutting the left side of the first clamp, and for the second clamp, you are cutting the right side of the clamp. So you can make two different B4 or Brinker clamp, and you can use it such as Brinker clamp. Just the problem is Brinker are more smaller than that kind of cutted butterfly clamps. So I mostly prefer B4, but if you don't have, you can make your Brinker clamp on self. Especially for the black triangle on the anterior region, they are very useful to retract the gingiva. And if you are planning to close the black triangle gaps here, you must retract the gingiva as much as possible. Then you can you can create your emergence profile like coming from the gingival pocket. The other one is the master clamps, and it classified to different. It's classified like a winged and wingless one. On the left side, my favorite wing clamp, and on the right side, you are seeing my favorite wingless clamps. And I mostly prefer wingless clamps because they are very useful when you are placing matrix span and matrix ring system. If you are using winged one, it may be very difficult sometimes, especially when you are placing the winged one on the second molar tooth. And if you are planning to do direct restoration, or if you are planning to place rubber dam, sorry, if you are planning to place matrix bands on the distal side of the first molar, these wings are making difficult to place your matrix system and matrix weights. And also, if you don't select the correct clamp, it won't fit the tooth. So the clamp won't be stable. And on the left side, the the touching point, the 26, number 26 has the two different touching point. And here is the touching point. So the clamp may be rotate around the tooth. And when you are, and if you create very big pressure on the rubber, then it likely pop out. So avoid this problem. We must select the correct size of the clamp, and it depends on the size of the tooth. But if you select the correct size, it means it must touch on the 4 point to the tooth, and it's more safer than the other one. And also, if you are selecting the correct size, you can make more retraction on the buccal area of the tooth, especially for the cervical abrasion. You can create more retraction for restoring the cervical area. And application methods, it's for the posterior restoration. Firstly, I'm placing my rubber dam clamp to the hole. Then I placed my rubber dam clamp and my rubber dam sheet to the tooth at the same time. Then I'm using my fingers and I'm trying to push them and I'm trying to place the rubber dam holes to the tooth like like doing flossing, and by the dental floss you can directly place the holes around the tooth. Before finishing, I need to place the rubber dam clamp again, and then I must do inversion. Now you are seeing on the buccal surface the tooth needs, the rubber dam needs more inversion to place my rubber dam into the gingival pocket. I'm also checking the leakage, the water leakage by by rinsing the rubber dam. And I'm asking my patients that, do you feel any leakage? Do you feel any leakage, any water inside your tooth? And if the patient tell yes, you may have some teared area, or you may have some holes on your rubber dam, which creates more leakage. So you must check it. After rubber dam, the main problem, I noticed that the main problem is, especially if you are taking photo, it's very big problem. But especially if you are taking photo and if you are working under microscope, you can see that kind of resins remainings easily. So I think I had a bit obsession, and I was thinking to clean the surface of the rubber dam clamps. It's very big problem if you are using the air abrasion with the aluminum oxide on your rubber dam clamp, because they directly make some scratch on the metal surface. Then I noticed that there's the glass beads in the market, and this is with the AquaCare, but you can use different airborne air abrasion instruments. The glass beads are being used by the dental technician to polish the metal surface like a partial teeth or inside the crowns. So the glass beads can polish and clean the rubber dam clamp surface, and you can get the result like this. And on the right surface, they are same clamps, but after cleaning with the glass beads, it's more polished and clean, and there wasn't any scratch. And the secondary elements are wax, wedge guards, stabilization cords, waxed dental floss, PTFE Teflon tape, gingival barrier, and gingival chalk. The first one is wax. The plastic wedges are not wooden one. It's very difficult to make it by using wooden one. The plastic wedge keeps rubber dam stable. They remove the sheet from the cavity border, like here, especially for the bottom border, and they avoid the tearing of the rubber dam, especially when you are using the instruments. If you touch on your rubber dam when you are cleaning, when you are making your preparation, if you touch with your burr to the rubber dam, they directly tear your rubber dam. So that kind of plastic weights are very useful to see the restoration border and to protect your rubber dam sheet. And the other protection method is interproximal tooth shield. And if you are using that kind of interproximal matrix system, they are making it easy to protect the proximal side of the adjacent tooth damage, and they avoid the iatrogenic factors. Otherwise, maybe you remember that photo on the first session, that patient had the food infection problem, and just the main reason was the iatrogenic factors. So when the other restoration was being performed, there was a small touch on the mesial side of the second premolar. So the other doctor, I think, create a latch on the mesial side of the second premolar. So that kind of materials, wedge guards, are very useful to protect the adjacent tooth. Then we widen the restoration area, and we make a dental direct filling on the mesial side to avoid the food infection. And the other auxiliary elements are dental flosses, but when we are buying the dental floss, we must be careful, and we should know how we can select our dental floss. Firstly, it should be waxed one. It shouldn't become fibrous, and it should be strong. Actually, in time, I noticed that that brand is the very useful and very strong dental floss, and I'm mostly using that one. But if you don't have, you must check and you must compare with the other dental floss in the market, and you can select the correct one. But the other important point is, when we are using dental floss, it should be located out of the restoration border, or else you may cover the floss with resin, and it's very difficult to remove the dental floss inside the resin. And even if you remove it, it means you create some holes inside the resin. So you should locate it out of the restoration area. And for laminate veneers for poly restorations, you can use dental floss. And for cervical restorations, Yes, you can use, but in this patient, I tried to use dental floss, but I noticed that the butterfly clamps were very more useful for that patient because that kind of butterfly clamps can directly retract the gingiva and it shows the and you can see the restoration area cleanly, more cleanly. And the other one is Teflon tape, and Teflon tape that we use in the dentistry is very not very specific Teflon tape. We can find it everywhere, and they can isolate the adjacent tooth before etching, before cementation, and also sometimes the tooth may have some different anatomy, especially on the distal side of that tooth here. So you can directly plug a Teflon tape here and you can cement your indirect restoration. Because the Teflon tapes are not very sticky materials and you can use it everywhere, like when you are doing resin restorations, you can directly cover the adjacent tooth before cementation and before under the nearby the gingiva to retract the gingiva because they don't stick to resin and you can directly spot it and clean it and remove it. Here the patient has fractured the lingual palatal cusp of her second premolar when she was eating olive. The seed of the olive directly touched to the this to the palatal side of the second premolar, and there wasn't any caries, but just because of the olive seed, she directly cracked or fractured her lingual cusp of second premolar, and the fracture line is almost at the same level of the alveolar bone. Then I use Brinker clamps and I use Teflon tape here to isolate the different anatomies, the leakage area, and I make the pre-endo build-up. So pre-endo build-up is very useful way for the second visit or for the second session. Before the direct or indirect restoration, if we make pre-endo build-up, then we can focus the remaining restoration. I made the medial side and then I made the distal side, and now I will create the palatal side of the restoration and the build-up. Then we made a root canal treatment. It's also useful for the indirect restorations, but even if you are doing direct, it's directly make easier to avoid the bacterial leakage. And also, I call it Teflon tape wedging technique. And Teflon tape wedging technique is very useful for a very different, very challenging case, and it makes restorable area for some very difficult cases. For the patient, there wasn't any adjacent tooth, so it's very difficult to place to stable your metric system. And for the single tooth, especially which has very deep cavities, deep caries, such as that tooth, like that tooth, it's very difficult to place to make stable your rubber dam clamp to your matrix clamp. And After placing my rubber dam clamp, I need to find a solution to to create non-leakage area, to isolated area. Then I placed a sectional metric system, and I used Teflon tape to stick my sectional band to the proximal side of the tooth. It's kind of wedging, but I'm using the support of the gingival pocket, and I'm plugging the Teflon tape inside the mobile gingival pocket, and then it makes more stable my sectional band. Then you can make your pre-endo build-up or any kind of restoration, what you want to do. And let's check how we make in practically. Here, the number 6 has the similar problem, and there was a different anatomy on the mesial, buccal and palatal side. And here I'm plugging a Teflon tape inside the gingival pocket. And then you can make your pre-endo build-up deep margin elevation by using the composite. Otherwise, I couldn't place any metric sweats here. It was the easier way for me, and then I made the immediate dentin sealing and deep margin elevation to that patient. Then we made our indirect restoration. The other auxiliary element is gingival barrier. Secondary element is gingival barrier, and we can stabilize our dental flows. And also the chalk or and putty kit is very useful, especially after placing your rubber dam. You may create that kind of tiered area, and especially for the lower posterior area, it's very challenging to isolate that area and avoid the saliva leakage from that area. So that kind of chalk make it possible to isolate here again, like what you see in that photo. And the other method is split dam technique, and especially the patient who has orthodontic retainer, it's very difficult to place the normal rubber dam technique. So for the split dam technique, you are just retracting the lips of the patients or the lingua of the patients for the lower side. You are just marking 3 points. The center one is I'm talking for the anterior restoration. The center one is the placed on the midline, and the left one is the second premolar, and the right one is the right second premolar. Then you are connecting bottom bottom marks with the top marks, but you shouldn't connect bottom marks with each other. Then you are placing it on the patient's mouth by using the clamp. You are stabilizing it, but still there's a leakage area. You must plug here. You must close that gap by using A-type or type C-type silicone, and then you can make your restoration. It doesn't avoid the gingival leakage, but it's directly retract the lips of the patients, and it makes very easier to work under the isolated area. And on the last step and the last type related to isolation, it is very important point. If you directly remove the rubber dam by pulling out, your patient may tell that what you want to do to me, do you want to kill me or any other thing? So it is safer and easier way to remove the rubber than by cutting it with scissors, and then you can directly place it